Hi everybody. So today I wanted to make a video specifically addressing some of the common questions that I get when someone is beginning to consider care with me, specifically pelvic floor care, as it might be something that they haven't been exposed to and it's just a new experience for a lot of people. We're not taught a lot about this by other medical providers in terms of what to expect. So sometimes there can be a lot of fear or hesitancy that creeps up, which is totally normal and understandable. And so hopefully this will help you if you're thinking about pursuing pelvic floor PT, or if there's someone who you think might benefit. Just having a little bit of this information might help to quell some of those fears and just ease your concerns. So this is specifically about what does a pelvic floor assessment look like with a PT. And first of all, I just want to point out that when I first learned about pelvic floor PT, my initial response was, how in the hell is this even remotely part of a physical therapist's scope of practice? But when you think about it, and then if you look back in some of my other videos, there's so many muscles in this region, and other providers, while they might assess the genitourinary or GI systems, they're looking at organs and other things that are really, really important, but they tend not to pay a lot of attention to the musculoskeletal component. But it's still very vital, and if we don't do it in this profession, who's going to do it? So a pelvic floor assessment is not like going to the gynecologist or like going to the urologist. There's no speculum, there's no stirrups, none of that. So I'm going to talk about the type of assessment I do for people with vulvas and people with phalluses. So it will begin similar to a lot of other physical therapy assessments. There's a pretty big chunk of just talking and interviewing and getting to know your symptoms, what's going on, what's been bothering you, how long it's been going on, specific complaints, etc. But from the physical standpoint, I usually have someone lay, if they have a vulva, lay on their back on the table, and I step out of the room so they can change. And there's a sheet covering them, but an actual sheet, at least for me, not a paper sheet that you might get at the gyno. And I prop pillows between the knees, and their legs are in kind of that feet together, knees apart, butterfly position, or sometimes I keep the feet flat on the table. And I start just by assessing and viewing the exterior like I would if I was assessing someone's shoulder or ankle. And I'm just looking at the tissue, I'm looking at the skin health as well, seeing if there's any redness, things like that. I always have gloves on my hands, and I'll start by asking someone to do a Kegel and then to do a reverse Kegel without really giving any cues. I just want to see what their baseline function is. And I'm looking at the genital area and seeing what movement happens there. Then I feel first externally. So I showed this model in one of my other videos, but this would be, so if someone's laying on their back, this is the view I would see. Their legs would come out from here. This is the pubic bone. So I would feel externally first. So if the legs are coming out from here, I usually actually walk down the adductors or the inner thighs first, and then I feel externally the tissue. There's a lot of different muscles I can feel externally. And then I change one of my gloves to go internally. Oh, sorry, before I do that, I test a few reflexes. So just like when you go to the doctor and they hit your knee with a little hammer, there's no hammer for this part, but there are reflexes, spinal reflexes there. So I use a Q-tip that looks like this, and I swipe one reflex kind of near the labia clitoris region, and then one near the anal opening, near the sphincter. And then if someone has pelvic pain, well, even if they don't, sometimes I'll take a different Q-tip. I'll put a little bit of lubricant on it. I use this lubricant here. It's called Slippery Stuff. Most people don't have a negative response to this. It's water-based, but if someone has an allergy, I definitely can take that into consideration. So I put a little bit of lubricant on this, and I just go barely on the inside of the vaginal opening. And I start at kind of this 1 o'clock region. So if 12 o'clock is the clitoris and 6 o'clock is this perineum space here. And I'll just feel in a clockwise motion something called the vestibule, which is the very opening of the vaginal canal. And then I will change my gloves. And then I will go internally, and just like I showed in my other videos, I start with the first knuckle, so first knuckle depth, and I'm feeling for all the different muscles there, like so. Yep, and then I'll go to the second knuckle, third knuckle, and at each layer I'm assessing for if there's pain, if there's high tone or tightness. I'm assessing for any scar tissue internally, any other tissue changes, and I also test your Kegel strength, your endurance, your power, and your coordination with a reverse Kegel. So that's a pretty typical pelvic floor assessment, and then afterwards I usually assess the abdomen as well, new set of gloves and everything. When someone either doesn't wish to have any type of internal vaginal assessment, or if they have a phallus, I can assess rectally as well. So this is the outside here. So this is the pubic bone, this is the anus, and then same idea. So there's this internal area. So very similar process. I'll still check some reflexes, but I won't be doing that vestibule Q-tip test. But people for this one are usually laying on their side with their knees pulled pretty far up. And same idea, I start with the first knuckle and I feel in a clockwise motion, and then second knuckle, third knuckle, testing for all the same things, strength, endurance, etc. Oh yes, and when I do a vaginal pelvic floor assessment, I will also check someone for pelvic organ prolapse as well. Yeah. So that's kind of the basis of what I cover, and I always tell folks that we don't have to do anything that they don't want to do. We can go as slow as someone wants. There's been times when I don't get past the first knuckle in an assessment. There's been times when I don't even go internal at all, either due to their comfort because their body's not allowing that, or it just triggers their pain too much. But I personally think that it's far less scary than going to a gynecologist, because there's no speculum. My finger is a lot smaller than that. And also, I think it can be easing for patients to know that as a provider, when I underwent this training and continue to undergo this training and continuing ed, we have to be the patient. We have to experience what it's like. So I have had these exams, both of them done on me personally. And so I remember what it's like to be on the table. And I tend to check in with folks maybe a little bit too much, just making sure that they're on board and that they're okay and they're, as comfortable as they can be. But yeah, so that's what you can expect from a pelvic floor assessment. Every PT is a little bit different, but I would say that's pretty standard baseline for most evaluations. But if you have any questions, please feel free to leave a comment below or send me a message through my DM. And if you are interested in scheduling a free 15 or 20-minute phone consultation to see if you would be a good candidate for this, please feel free to reach out to me. Thank you.